Welcome, everyone. I'd like to introduce Commissioner Kathleen Bahrain, who will start our program today.
Thank you, Patty, and thank all of you for joining us this morning. Welcome to our program, Understanding How to Access Insurance Coverage for Mental Health, Substance Abuse, Use Disorder Treatment. You know, one of the key missions of the Maryland Insurance Administration is to assure that carriers fulfill their contractual obligations to policyholders and insureds. And a very important part of that mission is to also ensure that providers and consumers understand their benefits and their rights. And programs like this are an important part of that educational process. One of the ways in which we equip you with the knowledge and the information that you need when you interact with your carrier. And as proud as we are to organize events like this to educate and inform, it is equally important for you to understand that the MIA is your resource, and we are here and available 24/7 to answer your questions. During the time of the pandemic, the administration has continued to investigate complaints without delay. We are here for you. You can visit insurance.maryland.gov. You can also follow us on social media. We're on Twitter, we're on Facebook, LinkedIn, Instagram, and Nextdoor. So we are very available and we want to hear from you. We're your insurance administration. You know, this program in particular, I think is incredibly important. And frankly, it was inspired by consumers. Through our mental health parity and network adequacy hearings, I heard story after story of people who struggled and found it difficult and didn't really understand what their rights are. And it took them a long time to figure out how to get access to the care that they needed, particularly the mental health care that they needed. And it became very clear to our staff that the process of winding their way through their contractual rights and really understanding what their rights were when they were not able to find an in-network provider, that people really needed to be empowered and educated and informed. And so that's what inspired this program today. And so I want to thank all the folks who've been part of those hearings and are helping us to make sure that we identify places where you need knowledge and you need to be empowered so we can provide that support to you. Mental health and substance use treatment is such a crucial part of healthcare, really at any time. But at this time, when our community continues to confront and to struggle with the COVID-19 pandemic, access to care is even more critical. And so I hope that this session is informative and helpful to you. And as you move forward, if you have questions, if you have concerns, if you encounter conflicts or resistance, please reach out to the MIA because we're here for you. Now, with that, I'm going to turn the program over to Patty Dorn, who's going to walk you through the logistics of today's presentation.
Thank you, Commissioner. Welcome, consumers, and welcome, providers. Again, my name is Patty Dorn, and I'm going to do a quick review of the rules of the event today. Firstly, our event today is being recorded. After our introduction, we're going to be running through several scenarios. So those are situations that you, a family member, or your patient may encounter while trying to obtain mental health treatment through your private insurance policy or plan. During the program, when you have questions, please utilize the chat box. So you're going to see that little button down at the bottom of the screen that says chat. Please stay muted and continue to use the chat box to ask questions throughout the program. If you joined us by phone, we ask that you call our office, and that's 1-800-846-4069 with questions, and you'll be routed to the appropriate person. And I will repeat this phone number again before the Q&A session. Breakout rooms will be available during the Q&A session. A breakout room is a chance for you to meet with a Maryland Insurance Administration team member individually to ask specific questions about individual circumstances. All other questions will be answered in our general Q&A room. You can request a breakout room with your question in the chat. So when you put your question in the chat and you want to ask your question in a breakout room, just say, I'd like to ask this in a breakout room, or just say breakout room. Also, you can just request a breakout room without posting your question into the chat, if that's what you're more comfortable with. And so with that, we have an important and much appreciated message from Lieutenant Governor Boyd Rutherford.
Hello, I'm Maryland Lieutenant Governor Boyd Rutherford, and I'd like to welcome you to this interactive event on understanding how to access insurance coverage for mental health and substance use disorder treatment. Access to mental health care and addiction treatment have been key priorities for Governor Larry Hogan and me since the beginning of our first term. In January 2015, the governor asked me to lead the Maryland Heroin and the Opioid Emergency Task Force, which resulted in numerous actions to address that devastating epidemic, investing critical funding, improving collaboration among government agencies, raising public awareness, and breaking down the stigma surrounding the disease of addiction. Through that work, I recognized the vital need to explore the mental and behavioral health needs of Maryland citizens. Just as there is a stigma attached to substance use disorder, issues related to mental health are equally stigmatized. In January 2019, Governor Hogan issued an executive order creating the Commission to Study Mental and Behavioral Health in Maryland to engage a wide variety of stakeholders to study the state's mental health delivery system. The Commission has released numerous recommendations to improve access to care. Insurance obviously plays a key role in accessing and delivering mental health care. That's why the information being covered here today is so important. I want all Marylanders to know their rights, how to get their questions answered, and their complaints resolved. The Maryland Insurance Administration is a great resource. The key mission of the Insurance Administration is to review complaints and provide an impartial determination of medical necessity of care at no cost to the consumer or provider. I want to thank Commissioner Bahrain and her committed team at the Maryland Insurance Administration for the critical role they play in making sure our citizens and healthcare providers are treated fairly when it comes to accessing and delivering care. I have every confidence that you will find today's event valuable and informative. Thank you for joining us today, and have a happy and healthy new year.
Kathleen, you're on mute.
Thank you. At least one person has to do that in every Zoom, circumstance. So I just want to thank the Lieutenant Governor for those words, and also for his own commitment and unflagging support of mental health and substance use disorder issues. I also want to thank my team here today for putting this program together. And most importantly, I want to thank each and every individual who came to us and who told us their stories and helped us understand how important it was to have this presentation today. So with that, I will turn it back to Patty. Patty?
Patty, are you on mute?
So maybe having a little technical glitch here. So I'm excited about this presentation. I just have to tell you guys, it's going to be really amazing in the way in which we've approached it. I am particularly excited about the breakout rooms as we've developed this hybrid program. And I'd be very interested in hearing people's feedback about how that works. The other thing that I'm excited to announce in due time is that, you know, the MIA is going to stand up what is essentially a virtual booth. So, you know, the MIA, Joy's team in particular, are out and about all the time. Libraries, senior centers, really literally every event where you can put up a table and provide, you know, MIA personnel to talk, that's available. You know, the MIA does that. Unfortunately, the pandemic has really closed a lot of that down. So we're excited that we are now able to recreate that virtually. And so that, watch for that announcement where we'll have MIA days, where you'll have the opportunity to meet with, talk to, and have one-on-one interaction, just like you would, you know, at any other type of event, or if you were at your local library or senior center. So we'll be bringing that to you later this month.
So Joyce, do you see Patty still in? Because I'm looking in the list of participants and I don't see her here. And that's not the end of the world because I've got her portion of the script here. So
I just texted you. I don't see her in the list of participants.
Okay, so just to keep things rolling, I will take over and do the portion that Patty was going to do, and we'll work from there. So you guys will have to settle for me. Sorry about that.
Joy, having you is never settling for anything. So thank you. Thank you for stepping in.
Not a problem at all. All right. So what we're doing this time, I mean, normally what we would do, we would be doing basically presentations. And Commissioner Bahrain thought that it would be a lot more helpful for people if we actually had actual scenarios so that you could hear real life instances and sort of see what the answers would be if either you were a consumer or a provider with this particular issue. So what we're doing is we're going to sort of give you a brief scenario, and then either Mary Quay, who is the head of our Life and Health Consumer Complaint Division, will provide an answer, or Lewis Butler, who is the person that handles the medical necessity. He's the head of that division. So the two of them will give you real world answers that respond to those particular scenarios. So the first scenario starts with, here's the issue. Jessica and Michael are worried about their daughter, Abigail, who is 15 years old. They aren't sure what the problem is, but it seems to be beyond teenage general moodiness. Abigail's grades are falling. She's gotten to a physical fight with her younger brother, and her parents think she may be drinking. Her school social worker suggested an evaluation by a psychiatrist. Abigail's parents can't afford to go out of network to get this treatment. How should they start the process to have Abigail evaluated and make sure that it will be covered? Mary, I want to turn this question over to you.
Okay, thank you, Joy. Well, a good place to start is with Abigail's primary care provider for recommendations of behavioral health care providers. And typically a referral is not needed anymore, but it can't hurt to start there. And Jessica and Michael can also start looking for psychiatrists through the carrier's online directory. They should check that they are searching using the right plan shown on their insurance card, because different plans may have different networks, and there will probably be options on the carrier's website.
So Mary, they actually tried the online directory, but they found that there were mistakes and it was very frustrating. What should they do at that point?
Well, there are laws requiring carriers to keep their directories up to date. And so if there is incorrect information in the provider directory, it is helpful if you report the errors to the health plan. And Maryland law requires health plans to list a way to report the incorrect information there on their website and requires carriers to investigate and update the information. And if they don't, then you can file a complaint with the MIA. Of course, in the short term, Jessica or Michael can also call the health plan for help and use the number on the back of their ID cards. There may be a separate number for behavioral health services, and some plans will provide additional help with finding a behavioral health provider if you ask.
So Mary, Jessica and Michael were able to get Abigail evaluated by a psychiatrist. And she was actually able to start making progress with an in-network therapist. However, before her therapy sessions were over, the therapist indicated that they were no longer accepting the parents' insurance. And Jessica and Michael have been unable to find another in-network therapist with the same level of expertise to treat Abigail. What should they do at that point?
Well, they can request a referral to keep seeing the same therapist. And Maryland law requires health plans to have a process to request a referral to an out-of-network provider if you need one and they don't have an in-network provider with the expertise. Now, to find those procedures, you can look in your policy or your certificate of coverage, or you can look in the health plan's online provider directory, because health plans are required to put that information with their provider directory. And the health plan is also required to provide the procedures upon request. So you can call and request them. Now, if a referral is given, the cost sharing will be the same as for an in-network provider. However, the provider may balance bill. And we have included a glossary with a link in the chat that explains what some of these terms mean if you're unfamiliar with them. Now, the health plan may enter into a single case agreement with the provider to prevent the balance billing. However, the agreement may be limited to certain services, and claims may have to be sent to a different address than the normal PO box that the carrier uses.
So, Louis, I want to turn this and ask you a question. Let's just say that the request was denied because the health plan says that there are providers in network, but Jessica and Michael don't think that the particular in-network providers have the necessary level of expertise, or that it's unreasonable for them to wait because there's going to be a delay before they actually get to an appointment. And they really don't want to disrupt Abigail's treatment since she's been doing well, and they don't want to see any deterioration in the progress that she's been making. What would you recommend to the parents at this juncture?
Thank you, Joy, and good morning, everyone. Jessica and Michael have a right to challenge or appeal the health plan's decision that its in-network providers are adequate. The health plan's decision to not allow Abigail to receive treatment from an out-of-network provider is considered an adverse decision, a determination that a proposed or delivered healthcare service is not medically necessary, appropriate, or efficient. Jessica and Michael have the right to protest this decision through the health plan's internal review process. When the health plan renders an adverse decision, they are required to provide the member with a detailed explanation in writing in the form of a letter, notice of adverse decision, or an explanation of benefits, EOB. Either document will instruct them on how to initiate the health plan's internal review process. If the health plan again determines that its in-network is adequate, Jessica and Michael may ask the Maryland Insurance Administration to review the health plan's grievance decision, the health plan's decision to uphold its adverse decision by filing a complaint. The MIA has the authority to contract with independent review organizations to review medical necessity complaints. Based on the IRO's medical opinion, the MIA reaches a decision either to uphold, modify, or reverse the health plan's decision.
So Lewis, another question for you. Let's just say that this particular situation has gotten worse. Abigail has threatened to kill her brother and herself, and it's clear that she needs emergency treatment. What can be done to make sure that she's able to obtain the treatment that she needs at this point?
In the case of mental health, emotional health disorder, or substance use disorder emergencies, if a patient is in imminent danger to self or others, and the determination is made by the patient's physician or psychologist and a member of the medical staff of the facility who has admitting privileges, then an insurance company cannot deny the first 24 hours of the admission based on medical necessity. So it's important that Abigail or that their parents notify the insurance company as soon as possible. For an emergency inpatient admission for treatment of mental illness, emotional health disorder, or substance use disorder, the insurance company must make a decision on whether to pre-authorize the treatment within 2 hours of receiving the requested documents. If the insurance company denies the request for an admission, call the Maryland Insurance Administration at 1-800-492-6116. The MIA is available 24 hours a day for complaints and emergencies when care has not yet been rendered. In an emergency, the MIA will make a decision within 24 hours. If the MIA does not regulate your health plan, your complaint will be sent to the agency that does regulate the plan.
So Lewis, let's just say that the parents have found, and it's been recommended, that Abigail go to this mental health facility that's located in Arizona, where they've got a history of dealing with these particular issues and dealing with it and having a lot of success. What should the parents do if they would like to send her to that particular facility?
It's important to note, inpatient care usually requires prior authorization. To start the process of obtaining pre-authorization, call the number on the back of the patient's health insurance ID card first. The insurance company will ask what healthcare services you would like to receive, and when appropriate, what facility you would like to use. The insurance company will tell you what documents it needs in order to decide if it will pre-authorize the healthcare service. Maryland requires that insurance companies accept a provider's uniform treatment plan form if the health plan is subject to Maryland law. A uniform treatment plan form is a document used by the provider to record the information needed by the insurance company to decide whether it will pre-authorize the requested service and/or facility. If the services are authorized under out-of-network benefits, there may be a higher cost sharing and balance building. Jessica and Michael can appeal the amount paid if it seems unreasonably low, and can file a complaint with the MIA if the carrier upholds its appeal. Lastly, the MIA can review whether the payment is based on their policy or certificate of coverage or violates Maryland law.
So let's just say that Abigail is actually been authorized to receive treatment, and she goes to the facility, and her treating psychologist says that she needs 2 weeks for the 2 visits every week for the next 12 weeks. And the plan says she can have 2 weeks for only 4 weeks. Is there anything that the family can do at this point?
Yes. First, if Dr. Gomez agreed to accept the authorization for 4 weeks, it may not be a denial. However, if Dr. Gomez did not agree, then we're talking about an adverse decision. Dr. Gomez can file a grievance on behalf of Abigail and her parents. Many providers get a written consent form as part of the paperwork for a new patient. Providers often try to call for a peer-to-peer discussion and become frustrated at the time it takes. Dr. Gomez can mail, email, or fax a written grievance, and the health plan will have to respond in writing. This may save time in the long run and will satisfy the legal requirements to exhaust the internal appeals process. If the health plan still says that 2 visits a week for 12 weeks is not medically necessary, then Dr. Gomez or Abigail's parents may file a complaint with the MIA. If the MIA can send the complaint to an independent review organization to get an opinion on whether the care is medically necessary.
So at this point, that ends the scenario. So now we'll be looking at the questions that are in the chat. And just a reminder, you can look down at the bottom of your screen and type out the question, or if you'd like to go directly to a breakout room, you can indicate that as well. I don't know whether Patty was able to join us.
I am here on the phone.
All right.
And
I can continue,
so,
Patty, since you're
yeah.
on the phone, so you can't see the questions in the chat.
Beautiful.
That's fine. That's fine. All right. So both Lewis and Mary are going to be available to respond to any questions. Also, we have the Associate Commissioner for the Life and Health Unit, David Cooney, who will also be able to address any particular questions. So what I'm going to do is I'm going to be looking through the chat and reading the questions. And David, Lewis, and Mary, I would ask if you believe the question is appropriate for you, or obviously if Commissioner Bahrain wants to chime in at any point, she would also just indicate so. So the first question we have is, can you speak about non-traditional or non-licensed mental health providers, sometimes referred to as peer counselors, life coaches, etc.? Given the scale of need, how are these types of services brought on board to offer service in a surge capacity?
Joy, I'll address this one. Typically, a healthcare policy will have an exclusion for providers who are not licensed. And a member has the benefits that are spelled out in the policy because that's the contract and subject to any exclusions. So if the policy does have a text that says that only licensed healthcare providers or certified healthcare providers acting within the scope of their license or certification are covered, unfortunately, that's going to be what is covered. And unless there is some kind of statutory requirement to provide additional coverage, that exclusion will apply.
Okay, the next question is, will you cover billing codes during this meeting? So maybe Mary, if you want to speak just generally a little bit about billing codes, but this may be one that this person needs a little bit of one-on-one assistance.
I'd like to know more exactly about what you'd mean by that. So that might be something to follow up with in a breakout room or offline if you follow up with us. Billing codes, I think what I keep telling my staff is the codes represent services, and the services are described in the member's policy. And so the carrier can look to see if the billing codes accurately describe the services, and then whether a service is covered or not is based on the member's policy.
So Mary Ellen, if you would like to speak one-on-one with someone, just indicate that in the chat and you will be given the opportunity to go to a breakout room and someone can address your specific concerns. The next question is coverage for dialectic behavioral therapy.
I guess I can answer that. Maryland's law requires coverage of treatment that is medically necessary and appropriate for the condition. So I don't think that there is anything specifically about dialectical behavioral therapy unless you have a question to go into in the breakout room. Typically, I would expect it to be covered, but it may be subject to concerns about whether it's medically necessary or appropriate.
The next question, why would a health plan be approved with no out-of-network coverage?
This is David Cunha. I can take that one. So it depends. There's various type of products that companies are allowed to offer in Maryland, and certain products to save costs and low premiums limit the providers to in-network coverage only. And that would be, for example, an HMO plan or an exclusive provider organization plan, which is often called an EPO. So those are permitted under law. Even in that situation, however, they are required to have an adequate network of providers. And if there is not a provider in the network that can provide coverage as needed, the companies are required to cover certain services out of network, and emergency services and certain urgent care services are always covered out of network. But typically it should be a consumer choice when they are selecting the product, if they would like to purchase a product and pay a higher premium for a product that provides in-network and out-of-network coverage, or if they want to save some money with a lower product premium, would be those types of products that limit you to in-network providers in most situations.
Thank you, David. The next question, what are the consequences for multiple violations for non-compliance of updating the directory? There is no incentive for insurance companies to comply if they can limit access to maximize profit.
So we have a couple of units at the MIA that can address violations of the law. First is my unit, the complaint unit. And so we act on individual complaints. And if we find that there is a violation of law, we can issue an order, and the order may include monetary penalties. Now, if we think there's more going on, we also have a market conduct unit. And the market conduct unit can go out to the carrier's offices, well, in non-COVID times, but they can do a more in-depth look and see how extensive the violation is, how often it occurs, what kind of procedures the company has in place to comply with the law. And so they can do a more in-depth exam and then issue penalties and require a compliance plan. Now, of course, it helps if we have complaints and can identify a problem. It lets us know that we also need to devote market conduct resources to it, though they may also look at it at other times as well.
And I'm not sure if you guys can answer this, but this is the next question. Is there a separate system or queue to get an initial triage appointment promptly, even if wait times are generally long?
That would depend on the health plan and the providers. We have been told that some health plans do have that kind of system. I did refer to the possibility of asking for extra help finding a mental health provider, and I don't want to single out any carriers because I don't know what all of them have, but we have had some of the health plans tell us that they will help you get an immediate or urgent appointment if you ask for that help when you call.
And we've received a couple of requests asking whether the scenarios would be available. And the answer is we're recording this entire presentation, and by the end of the week, it will be posted online so that people will have access to the entire presentation, including the scenario. And I have seen several notations that we need to try to do, and we are all very guilty of that, of trying to make sure we always speak in plain language and not use our typical insurance jargon, because that is not something that consumers are familiar with. And we will all definitely try to do better with that. That's something that we all tend to fall back into. The next question, how long do all of these processes take in terms of authorizations, appeals? And I think that's probably a blended question for both Mary and Lewis.
Mary, I'll take this one initially. As I referred to earlier, if we're dealing with a medical emergency, the administration has 24 hours to resolve such a complaint. Otherwise, the law provides us with 45 days from start to finish to investigate a complaint where the denial is based on medical necessity. That means 45 days from the time that we receive the complaint until we actually conclude our investigation. So it really, the time frame will be determinative based on the medical necessity or the urgency associated with the complaint that we actually receive. So we're looking, you would be looking at anywhere from 24 hours to 45 days.
So for the carrier's internal processes for authorizations, Maryland law allows them 2 working days from the time they receive all necessary information. And so they have 2 working days normally. I think, Lewis, is it 2 hours if it's a mental health emergency?
That's correct.
Okay. So that's their time frame to turn around an authorization. If the care has not been provided yet, there are processes to get an expedited appeal within the carrier's process. And there are also processes to come straight to the MIA, or usually to Lewis's section, because it cannot wait while you go through that process. So again, it's going to depend on whether the services have been provided yet or not. And you can request an expedited appeal, or you can call the MIA. We're available 24 hours and say that you need something, you think it deserves that you can come straight to us. Now, if it is not medical necessity, you first should file an appeal, and the carrier has 60 working days to resolve it, unless it's a case where there is an urgent situation involving care that has not been provided. But typically they will have 60 working days to resolve it. This happens most often for claims complaints where it's a CPT code or something else that is not medically necessary. And then you can file a complaint with us. And most of our complaints are resolved within 90 days.
Okay, the next question. Thank you both, Mary and Lewis. Is there a Maryland standard uniform treatment plan that is used by all carriers in Maryland?
Yes, it is established by regulation.
And if anyone would like more information about that, you can either reach out to Mary or Lewis or David, and they can give you some more information about that particular treatment plan, because I see that is from one of the mental health providers. So if you have some specific issues or concerns about that form, feel free to reach out to any of those three and they can help you with that. Okay, the next question. In case of a transfer from an out-of-network to an in-network provider, will a provider-to-provider consult be covered in support of a smooth transition?
It's going to depend on the terms of the member's policy. That's something where I'd really need to see the specific situation. It's not something we can address in a general way.
And I think the next question has actually just been answered. It was how long it takes to review the MIA, how long does it take the MIA to review complaints? And as both Mary and Lewis indicated, it's going to depend on the type of complaint and the issue. So it varies anywhere from a few hours to around 45 to 60 days. The next question, does the MIA's review process ever involve speaking with the providers above and beyond the uniform treatment plan form?
When we receive a complaint, there will be times when we may need additional medical information or clarification, and that typically will come from the patient's healthcare provider. So long as we have that information, there are times when we will send a letter to the patient's treating physician to get additional information that would assist us in rendering a determination. So the answer to that question would be yes.
Thank you, Lewis. Next question. What if the insurance company does not require an authorization for outpatient visits for the patient's diabetes, but on the behavioral health side, outpatient services do require authorization? Is that a parity concern?
I'll take that one. So it's definitely a parity concern. We couldn't say for sure whether it's a parity violation without investigating it more and looking at the entire contract. But generally, if they're requiring prior authorization for a certain type of service on the medical side, but not on the mental health or substance abuse side, that would be a parity violation. There's policies and procedures that go into that. There's just the one example here is diabetes. It would be possible that prior auth was not required for diabetes, but was required for other medical surgical outpatient visits, and it could technically still comply with parity. So we would have to look at that and investigate it on a case-by-case basis. But those are the type of issues we would certainly like to be made aware of, because that's definitely a big red flag there.
Thank you, David. Next question. Does any of this information apply to national counts? For example, the employer group is not based in Maryland.
In general, probably not. The general information will apply, but Maryland law specific information will not. Because we are limited to contracts or policies issued in the state of Maryland for insured plans.
Thank you, Mary. Next question. Can DBT be covered by Maryland Health Insurance for DBT offered by cash-only practices? Is the covered person allowed to request reimbursement?
So in general, yes. But it can get a bit complicated because Maryland has laws about HMOs, health maintenance organizations, that are designed to protect consumers by holding them harmless for any charges except for their regular cost sharing. And what this means is that, you know, if your treating doctor gives you a referral to or directs you to go to a specific other treating provider, that may be covered even if that provider is out of network or in an emergency situation, as examples. And what that means is Maryland law sets a payment rate that the HMO has to pay and that the doctor has to accept. Now, the issue with when you say a cash-only practice is you can also enter into an agreement with a provider and say that you will not file a claim so that the provider will not be bound by the HMO's payment and the protections in law. And so that's where it can get a bit complicated. Now, if you're in a PPO and you go to an out-of-network provider and pay cash, then you can file a claim to get reimbursed. My question would be that if you're going to a provider who is cash only and is unwilling to give you the information to file a claim, you may have problems because the health plan is going to want to know what services were provided, what the diagnosis was, and specifics, which are usually expressed using CPT codes and diagnosis codes. And so if the provider is unwilling to give you CPT codes or diagnosis codes, it may be practically very difficult for the patient to file a claim.
Thank you, Mary. The next question. Who decides what is medically necessary? Some insurance companies are auditing after a certain number of 90837 60 minutes versus 90834 45 minutes to disincentivize the use of higher rate treatment sessions.
I'll take this one. The carriers are required to have an internal appeals process in place, and that process is monitored by a board certified physician within the carrier. So the carriers, when they're conducting utilization review in order to determine whether to establish medical necessity, that has to be done by a board certified physician. With regards to the second portion of that question, Joy, I would encourage that caller or the individual to actually reach out to us via the chat room or to actually file a formal complaint with us so that we can receive more detail with regards to provide more specifics to that particular request. But in general, the carriers are required to, whenever they conduct utilization review to establish medical necessity, that has to be done by a board certified physician who has skill or understanding in the condition that's under review. So it's very important that whenever the carrier renders a medical necessity decision or decision based on medical necessity, that decision has to be rendered by an individual who's a board certified physician.
Thank you, Louis. And
Joy,
Oh,
I would
go
also
ahead,
say,
Mary.
when it comes to audits and CPT codes, what we see, and this is not just in mental health, we see it a lot for emergency room physicians and other types of providers, is that the carriers are also looking to see if the medical records document that the services described by the CPT code were in fact rendered. So for many visits, there are 5 levels of codes. And so if a provider typically bills a level 5 code far more often than peers do, the carrier may audit and look at the medical records, not for medical necessity, but to see if the code is appropriate to describe the services.
Thank you, Mary. And Lewis just reminded everyone, if someone right now would like to receive one-on-one consultation, they can ask to go to the chat room. Yes, Commissioner.
Joy, I'm sorry to interrupt. I just needed to let everybody know that unfortunately I have to drop because I have a meeting that I have to go to at noon. But I cannot tell you how pleased I am that folks have come on and are asking such really good and thoughtful questions. And I encourage people to stay and to continue to participate at this level for the remainder of the program. And to take advantage of those one-on-one opportunities. Again, we're here for you. We're here to empower you. We're here to teach you and to really help you work through these issues. And, my staff are among the best state workers in our system. They are dedicated, they care, they're available, they're responsive. And I want you to know that and understand that and never hesitate to reach out to us because we do care very much about these issues, particularly with respect to mental health issues. And I will just emphasize one last time that it really has been the bravery of consumers that have shared their stories with us in our public hearings that inspired this. So continue to reach out to us and tell us where you need our assistance and where we can have additional programs like this to provide education and support and empowerment. So with that, I'm sad that I have to leave you, but I leave you in the most capable of hands, as you can tell. Thanks, guys. Take care.
Thank you. So the next question, how does one know if the carrier's contract with providers, whether in or out of network, who provides quality care and are co-occurring capable in order to treat individuals who have both substance use and mental disorders?
You should refer to the carrier's network of providers. The carriers are required to provide that information to their members. The member can reach out to those particular providers that have been identified to determine whether or not they meet the satisfaction of the particular member insofar as, do they have the training, do they have the skill, is this an area of expertise that they regularly engage in? Do they see patients on a regular basis? So the first I guess starting point would be to reach out to the carrier to receive the network of providers in that particular area, and then do some additional research as the member is able to do.
So the next question, what happens if a client in a similar scenario, and obviously they're referring to the scenario that we went through in the presentation, has private insurance and Medicaid, and residential treatment options provided are not approved by private insurance for private authorization? Can they then bill Medicaid if accepted, or look for RTCs, and that would be residential treatment centers, that would take Medicaid?
So it can get a bit complicated when you have two different health plans, whether it's Medicaid and private insurance, or even if you have coverage under two different health plans, because like a child might be covered under each parent's employer plan. And there are rules about determining which plan is primary. Typically, you do have to follow the rules of your health plan to have the health plan cover it. Now, Medicaid is a little bit different because it's a government program, and it will typically seek to recoup its costs from the private health plan. I'm not sure about the description of the details at the end. I will say I have seen the scenario typically comes about in cases of childbirth, because pregnant women qualify for Medicaid more often than people who are not pregnant. And so that's the scenario I'm most familiar with. And you still need to follow your regular health plan's rules, even though then Medicaid may try to recoup the money. But to have it covered, typically you need to follow the health plan's rules.
Thank you, Mary. Next question. If the provider does their due diligence in using the DSM-5 to determine diagnosis and determines that a particular type of therapy aligns with the treatment plan, then it sounds like the insurance carrier has the last word on treatment choice based on their policies. Is that correct? If so, that is unfortunate and may not allow the therapist to adequately advance the change process.
A big part of whenever a treating physician or provider recommends a particular course of care, there will be, we've seen complaints where the carrier's medical staff, their physician, they've denied it. Typically, those are the sort of complaints that's not the end of the inquiry. We have the ability to investigate those complaints. So the carrier doesn't necessarily have the final word. If what is being proposed that has been determined to be medically necessary after we've had the opportunity to gather all of the necessary information, this is assuming that a complaint has been filed with the Maryland Insurance Administration, and the case has been sent to an independent review organization, and that determination comes back, that's what's been requested by the patient's healthcare provider is medically necessary, then at that point, the administration can require the carrier to authorize what has been requested. So there is a process in place. The carriers are required to have their internal appeals process, but simply because the carrier upholds their determination does not mean that that's the end of the inquiry. The Maryland Insurance Administration is available to investigate those types of complaints.
Thanks, Louis. And I just wanted to also offer one point of clarification to the way the question was worded. The insurance company never makes treatment choices, period. They make their determinations are based on reimbursement and whether they will pay for it. And now, of course, I understand who pays for it in most cases. If it's expensive treatment and the insurance company's not going to pay for it, then the consumer's not going to be able to get that treatment because they're not going to be able to afford it. But I did just want to clarify that the treatment choices are always up to the provider. The insurance company's determinations are based on whether or not they will reimburse for that treatment.
Thank you, David. The next question. How does the MIA look at the carrier's way of defining medical necessity for treatment of a problem? For example, a patient has been abusing opioids and has had near fatal overdoses. That patient presents for treatment. However, they used a few hours before coming for treatment, so they are not experiencing medically life-threatening emergency at the time. the carrier may state the patient does not meet medical necessity. However, the patient is at danger for relapse and possible overdose if not authorized.
Joy, typically that sort of complaint, we're going to be relying on the medical records, the patient's medical records, because the medical records speak for the patient when the patient cannot speak for themselves. So in a particular case where the medical records document the patient's history, the fact that there may be some ebbs and flows in terms of their use, that would not necessarily negate or not establish medical necessity. Again, we would be reviewing the patient's medical records to establish medical necessity, not necessarily looking at where the patient is at a particular point in time. So again, the medical records are critical to a complaint investigation that the administration would undertake. And then again, we do have the opportunity to forward those medical records and have them reviewed independently. So we would be looking at the totality of the circumstances associated with a patient, not necessarily a little window.
And Joy, I would also like to point out that in that case, in determining if it qualifies for an expedited review, our regulations say that it can be an emergency case if without immediate medical attention, it could cause the member to continue using intoxicating substances in an imminently dangerous manner. And we also, I'm looking to the side to read the regulations. It may also be a reason to come directly to the MIA if a member is in danger to himself or others, but that includes if the member is unable to function in activities of daily living or care for self without imminent dangerous consequences. So the danger to self is more broadly defined there in cases of substance use disorder.
Thank you both, Mary and Lewis. The next question. Can consumers receive a refund for poor or unsatisfactory, service, such as being diagnosed with bipolar when the actual issue is borderline personality disorder?
It sounds like that would be a provider issue, and we do not regulate providers. We can only regulate the health plans and enforce the insurance laws of the state.
Thanks, Mary. The next question. Does the MIA have any jurisdiction or relationship regarding employee assistance programs funded by employers? Can we discuss MIA outreach, how EAP, that's Employee Assistance Program, is often underutilized?
So this is David. In all likelihood, we would not have authority over EAP services. I should mention here when they're funded by employers, if it's part of a self-funded plan, it's not something we have authority over. If it was actually truly offered by an insurance company, through an insurance company, maybe we would, but my understanding, I don't know if Mary or Lewis has any more insight, but most of the EAP services I'm aware of are directly funded by the employers, which means we don't have jurisdiction.
Thanks, David. The next question. Is there a guideline for how many in-network providers a consumer should contact with no success before they file a complaint? What about the distance access? Also, how does one prove that they have been attempting? In this market, there are no answers from providers or insurance representatives who provide the consumer with an inaccurate list?
Well, you should review the carrier's offering. Obviously, if the carrier, you make your request to the carrier that you want to see a particular physician or that you have a particular need. In response to that, the carrier will provide you with their network of in-network providers. When you go through that network, if it's established that they don't have a provider that meets the patient's particular need, what you in essence have concluded is that the carrier's network is inadequate. We do investigate those sort of complaints insofar as giving you a specific number of providers that you need to reach out to before you can establish whether their network is inadequate. I don't necessarily have a number to give you, but we do reach out to, when we receive those sort of complaints, we actually not necessarily stand in the shoes of the consumer or the complainant, but based on the information that we would receive from the carrier in response to such a complaint, we would reach out to some of those providers that they provided us with their contact information to determine whether or not they're seeing patients, is there a waiting list, things of that sort. And then to your earlier point with regards to time and delay, they are also factors in considering whether or not a carrier's network is adequate or inadequate. So it is a process that one would have to go through, but what I would encourage you to do is, if you have any questions, if you have a specific complaint in this area, feel free to give us a call, reach out to us, and we'll be more than happy to investigate that complaint.
And Joyce, if you could put the 800 number for the MIA in the chat box, so that if people want to reach out after this call with any questions, and you use that 800 number, and then you can just ask for, and basically tell the person what your question is, or follow the prompts and speak with someone in the life and health section, which is Mary's section, or in the appeals and grievance section, which is Lewis's section. All right, the next question. In regards to the example given about the insurance carrier auditing certain services per certain codes in terms of medical necessity, did I understand that the review is being done by a provider board certified who works for the same provider that is auditing the service?
The carrier's internal, there's an interesting, the internal appeals process the carriers are required to have in place. There is the initial adverse decision that is rendered by one individual board certified physician. The appeal is reviewed by a different physician, board certified physician. So the same person is not rendering the initial denial and then reviewing their own denial and approving or continuing to uphold their decision. So there is a process in place where you don't have the same individual who rendered the denial also reviewing the appeal or the grievance.
Okay, and then thank you, Lewis. And here's our next question. I am still having difficulty finding a pediatric counselor, as most of the providers listed in the Insurers network are, as many have closed or moved 45 minutes or more away from our home. Others listed are not taking new patients. So I guess the question is, what can they do?
Well, this may be a situation where they could request a referral to an out-of-network provider. It may be useful for them to use the breakout room to talk to someone in more depth.
All right, the next question, and I'm not sure if anyone knows the answer to this. Is there a Maryland medical agency responsible for alternative treatments and differences of professional opinion or perspective about the overall philosophy of mental health care, is there a Maryland agency facilitating culturally aligned mental health care and addressing complaints of microaggression?
That would, if there is a board or group that looks at that, that would probably be within the Department of Health. And so it may be useful to reach out there. I don't know if the Behavioral Health Administration looks at that kind of thing, but they may be a place to start.
And Mary or Lewis, if one of you could summarize again how someone can receive out-of-network service if the appropriate in-network service is not available.
Go ahead, Mary.
Okay, well, the first thing that you would do is reach out to the health plan, and they may have different terms for this. I think one health plan calls it a gap exception. But say that you want to get a referral to see an out-of-network provider as if they were in network. And they should be able to describe how to do that. And they also ought to have their procedures with their online provider directory, as well as send you those if you ask for them.
And I think this might be the last question. Our facility has been having difficulty obtaining authorization under Optimum Health, under Medicaid, congruent with DDA funding. We were advised to drop those individuals that we have been providing services under the psychiatric program. So I guess they're just looking for guidance as to what they should do.
And we cannot regulate that because it is part of Medicaid, and we have very limited authority over entities that work with Medicaid, such as the MCOs, but we do not regulate Optum when it is working for Medicaid.
And that's all of the questions that I have in the chat. I will give people another couple minutes in case they have any questions for the chat, or in case they wanted to have a one-on-one session in the breakout room. And I'll also tell people that we will be posting this recording online, but I have seen several messages where people have indicated that we went through a lot of material and they would like maybe for us to give them some type of a written document. And I can tell you what we may consider is to think about whether we will create some type of a question and answer document based off of the questions we specifically received here today. But that will obviously take us a little bit of time because this has been a relatively lengthy session. So give us some time, but also what you should do is look at our website because there's lots of information there, but then also feel free to contact us, and we have people that are available to answer your questions, and people can file complaints. One of the things that we frequently see is we have these great sessions and we talk about all of the issues that folks have, but then we don't necessarily receive the complaints after the fact. And I know even though Mary and Lewis are very busy, they are here to help and are more than willing to help handle your complaints. So we've got another couple questions. Is there a way Maryland, whoops, give me 1 second in the middle. Is there a way Maryland can add a policy to mandate insurance to explain the right to out-of-network providers when they are unable to find one timely, and provide a detailed process of how to do so?
So this is David. The MIA is not able to mandate things that are not already required by law. That would require legislative change. But for this particular issue, insurance companies are already required to post the procedures for requesting access to an out-of-network provider when an in-network provider is not available. I think it has to, if my knowledge is correct, has to be in the provider directory and on their website where consumers can access it. I believe I have heard from certain consumer advocates that I think some people feel that the current disclosure is not adequate. But there is currently a Maryland law that does require a certain disclosure. And if there'd be a need for a different type of disclosure, it would require legislation from the General Assembly.
And then the next question is, where would a person be able to find the presentation? By the end of the week, if you look on our website, there's an icon that you will see that says webinars and videos. Click on that particular icon and you will see, once this presentation has been posted, it will be listed there. The next question we have, what steps is the MIA taking to require insurers to notify consumers of their rights and the complaint processes?
The carriers are required by law to provide information regarding not only the Maryland Insurance Administration, but also the Health Education and Advocacy Unit within their Notice of Adverse Decision letters, also on their EOBs to provide that information. So the carriers, they're well aware. Whenever you receive a denial letter or a denial is issued by a carrier, it provides information regarding how to file an internal appeal, but it also provides you with information as to how to file a complaint with the Maryland Insurance Administration.
So I'll give folks another couple minutes in case they have any additional. Wait a second, looks like I do have one more. How do you define adequate? I am behavioral health policy researcher and a clinician, and I can never find it, and guarantee you majority of consumers and providers are unaware. So how do we file a complaint about making sure insurance clarifies this?
So I'm not sure if I 100% understood the question, but there is a Maryland regulation that defines network adequacy according to a certain specific standards related to how far away certain specialties and providers are from the member's home residence, wait time, how long it takes to see an appointment for certain types of specialties, and then provider to enrollee ratios. So how many providers are in a carrier's network for each member who is in that network. And that is a process that we have existing regulations. There was a law passed, I think in 2017, and it required our agency to adopt regulations to establish those standards. And we are actually currently looking at them now to revisit them. And we've had some public meetings. And so we are certainly soliciting comments on any changes that should be made to those regulations. And those regulations can be found on our website, but currently that is how adequate network is defined. It's according to the MIA's regulations.
And this is a comment, and I don't know if someone can say anything about this, and this goes back to getting treatment. Basically, the person is saying this doesn't help if you can't provide a treatment and therefore you don't get the denial. What are there any options or anything that consumers the consumers can actually can do, because they can't even find a provider to get treatment? So I guess this really goes to the question of, if you're having difficulty getting a provider, you should file a complaint with us and talk about and basically explain what your issue is with getting that provider. And then maybe someone at the insurance administration here can assist you with what your options are. And to the extent that people don't know that the MIA exists, I would ask all of you on this particular call to make sure that you let consumers, your friends, your families, your coworkers know that there is an agency to assist them with their private insurance issues. And that brings me to what I think might be the last question. Most consumers have Medicaid and Medicare. Is there an equivalent authority like the MIA that can assist them?
Well, Medicare and Medicaid are two separate entities. Medicaid is a state-federal partnership, and I will not pretend to know a whole lot more than that. But if someone is enrolled in an MCO, I know the Department of Health does have helpline numbers for people in the Health Choice program. And if you send a complaint to the MIA about an MCO, we will certainly forward it to the correct person at the Department of Health. For Medicare, it's purely federal, but each county in Maryland in their Department of Aging has a SHIP volunteer program, senior health insurance plan program. Anyway, and I know there are some counties where they are very knowledgeable and very assertive in helping consumers exercise their rights regarding Medicare. And so they may be able to provide help.
And it looks like we have another question. For when filing a member reimbursement forms for out-of-network services, the insurance company often makes some error in reimbursement or loses the claim when multiple calls are required to eventually get reimbursement. Is there any accountability for insurance companies to process claims in reasonable timeframes without error?
Maryland does have what's called a prompt pay law, and that requires carriers to process the claims within 30 days, where they can pay, deny, or request additional information. So if you have any evidence, and this can include good documentation in your own notes of when you sent the claim, how you sent it, and what you sent, that's helpful. And you can file a complaint with the MIA if you are not getting timely responses. Of course, it can be difficult if there is a dispute over whether the company ever received the claim. So please be sure that you use the correct PO box, etc., for sending in your claims.
That looks like that's our last question. So I want to thank everyone for attending. And as we've said, feel free after the fact. Oh, let's see, wait a second. Another question. While I think current regulations limit how much the MIA can impact carriers rationing their coverage of BH treatment, I do appreciate this effort. And I have not, there have been many, and I should say this to Louis, David, and Mary, there have been many thank yous. I've not been reading them, but it sounds as if all of the participants were very, very thankful for the time that the three of you spent with them today. And thank you all again. And going forward, if you have any additional questions, feel free to reach out to us. Have a great day.